The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Allie Strong Martin, and I am the Communications Coordinator at Anchor. We are so glad that you joined us today, and it is my pleasure to introduce today's speakers. Before I do that, I will share a few housekeeping items. Today, during this webinar, if you have any questions, please type them in the questions box, which you'll find in the webinar panel. There's also in the webinar panel a handout for today's session, and this handout will also be shared with you after the presentation. And now for speaker introductions. Maureen Reagan has over 35 years of experience providing support for people with IDD, their families, and their caregivers. Prior to joining IntellectAbility as Director of Public Relations, Ms. Reagan served as Bureau Chief for IDD Services and as Senior Medicaid Policy Administrator with the New Hampshire Department of Health and Human Services, was the Manager of Care Management for a Boston-based Medicaid managed care organization, and a principal with Mercer Government Human Services Consulting, where she provided clinical and policy supports to state Medicaid programs across the nation. Ms. Reagan is passionate about educating and informing those responsible for maintaining and restoring health, wholeness, and a good quality of life for people with IDD. Dr. Craig Escudé is a board-certified fellow of the American Academy of Family Physicians and the American Academy of Developmental Medicine, and is the president of IntellectAbility. He has more than 20 years of clinical experience providing medical care for people with IDD and complex medical and mental health conditions, serving as medical director of Hudspeth Regional Center in Mississippi for most of that time. While there, he founded DETECT, the Developmental Evaluation, Training, and Educational Consultative Team of Mississippi. He is the author of Clinical Pearls in IDD Healthcare and the developer of the Curriculum in IDD Healthcare, an e-learning course used to train clinicians on the fundamentals of healthcare for people with IDD. Dr. Maulik Trivedi is a board-certified emergency medicine physician in practice for over 20 years. He has served as the chairman or associate chair of several emergency departments. He has also been an integral part of the core leadership of emergency medicine provider groups in the region. He is a founding partner of StationMD and has been instrumental in helping the organization achieve its mission of improving the quality of care for the IDD population. He is a recognized national speaker and thought leader on the use of technology and telehealth solutions to positively impact an individual's medical care and foster independence. He continues to practice as an ER doctor in the New York City area, and he and his family currently live in Midtown Manhattan. And we were originally going to have Kim Stock presenting today, but we are so very fortunate to have Jessica Bax presenting in her place. Jessica Bax is the director of the Division of Developmental Disabilities for the Missouri Department of Mental Health. The division has a team of over 2,000 staff dedicated to ensuring individuals with developmental disabilities are able to live their best lives, and strives to achieve this mission through a variety of programs, including the Medicaid Home and Community-Based Services waivers, autism services, and state-operated programs. Prior to joining the Department of Mental Health, Ms. Bax served for 3 years as the Division Director of Senior and Disability Services with responsibility for Medicaid Home and Community-Based Services, Adult Protective Services, and Older Americans Act programs. She has more than 17 years of government experience, including serving as the Constituent and Emergency Services Manager, Bureau Chief of Medicaid Long-Term Services and Supports, and Deputy Division Director for Senior and Disability Services. Ms. Bax currently serves as a national board member for Advancing States. Thank you to all of you again for being here today, and now I will turn it over to these wonderful presenters.
Thank you, Allie, and thanks so much to Anchor for supporting today's webinar. This is Laureen Reagan, and I'll be starting out our presentation on health risk-informed telemedicine. And as we start today's discussion, we'd like to start it with some information about health disparities for people with intellectual and developmental disabilities. There's been lots of information in 2022 published about health disparities for people with IDD and the impact that these disparities have on their health and well-being. And we'd like to be sure that we create a strong foundation for today's discussion by talking about a couple of key points. Health disparities, as most of you are probably aware, are the preventable differences in disease, injury, violence, or any other opportunities to achieve optimal health. And these are disparities or differences that are experienced by socially disadvantaged populations. Many of you have seen or read through the 2022 National Council on Disability Health Equity Framework for people with disabilities. And this is a framework that was published in February of this year that pointed out the risk that people with physical, intellectual, or developmental disabilities have for health disparities. There are a number of things that contribute to these disparities, and one of them is disability bias. And disability bias is negative perceptions and inaccurate assumptions about the quality of life of a person with a disability. And they're often unconscious. It's not something that most people think about, but it's there. And when we think about unconscious bias on the part of healthcare providers, it's important to understand that they're not exempt from this kind of deficit-based thinking. And healthcare providers, particularly for people with IDD, have a high level of influence in healthcare decisions that are made. And in some cases, this bias can lead providers to believe that care, including preventive care or chronic disease management care, is not necessary for people with IDD. There are also misconceptions about the medical model, and these misconceptions contribute to health disparities. Many of us who have been in the field have heard for a long time that they don't want to return to the medical model of supports and services for people with IDD because this is a model that views disability as a defect. And what we would say about our work collectively to support optimal health outcomes for people with IDD is that it's important to recognize and focus on the approach that is most acceptable to people, which is the social model, and really looking to promote access and accessible environments for all. And we mention this because it's not unusual for nurses, physicians, other clinicians in the field to hear from our colleagues that they're really not interested in promoting a medical model when we talk about things like promoting health equity and ensuring that people have appropriate access to health care. And we want to assure them that that's not our goal. We're looking to ensure that people with IDD have better health outcomes. And we actually reject discussions about the medical model because we're concerned about this misconception actually contributing to continued health disparities for people with IDD. We'd also like to talk about and mention diagnostic overshadowing and the impact that this phenomenon has on health disparities. And just a couple of months ago, in June of 2022, the Joint Commission, the national accrediting body for healthcare facilities, issued a sentinel event alert to alert providers about the risks of diagnostic overshadowing for people with disabilities. And this is something that stems from cognitive bias. And most of us have seen this. It's essentially what happens when a person with an intellectual or developmental disability presents to a clinician or a healthcare provider with a change in behavior. And supporters are trying to help those who are providing the clinical supports understand that these are different, that these behaviors are different. So a person perhaps experiencing pain, maybe banging their head, They may be crying out. They may have lots of different ways of trying to communicate their discomfort and their pain, but these symptoms are discounted and attributed to the person's IDD. This results in an incomplete assessment, and other differential diagnoses are not considered, and as a result, medical conditions continue untreated. It's also not uncommon to see psychotropic medications given to treat the person's symptoms, which of course don't work because the person may be presenting with a medical condition. This bias is usually unconscious, and it can be addressed through healthcare provider education. We know also that something that also contributes to health disparities are gaps in preventive care. We recognize that during the COVID-19 pandemic, many people either deferred or missed preventive and ongoing health care, and many are continuing to try to catch up. It's important to recognize, though, that these gaps in preventive care are magnified for people with IDD, and that this is not new. Even before the onset of the pandemic, Medicaid beneficiaries overall, in general, were not receiving age-appropriate preventive care, and only 1 in 4 adult Medicaid beneficiaries of the appropriate age had received a colonoscopy in the previous 5 years, as an example. So you can see some other examples here on the slide, but really, I think the other piece to really recognize and address is that there were differences also found in health screening rates among adult Medicaid beneficiaries that were magnified by race and ethnicity. We know that there can be a strong and positive impact on health disparities for people with IDD through clinical education. A recent study showed that 82% of physicians reported that they felt that people with significant disabilities had a worse quality of life than others. Also, that 41% of physicians were 41% were very confident about their ability to provide the same quality of care to patients with a disability. And only about 57% strongly agreed that they would welcome patients with a disability into their practice. So we can see that there's a concern on the part of clinicians about their ability to support people with disabilities in their practices. There's also been lots of discussion around social determinants of health and the impact of social determinants or unmet social needs on health disparities. And social determinants really revolve around where we're born, where we live, our education, our employment, our age, other social factors. And we know that people with intellectual and developmental disability are more likely to have unmet social needs across all of these domains. And this is important because it's estimated that about 80% of a person's overall health outcomes are related to their social needs and whether or not they are met, and only about 20% related to the actual medical care that's provided. We want to mention as well that, and particularly for today's webinar, it's important to recognize and appreciate the significant impact that direct support professionals, or DSPs, have on health disparities. We know that they play a critical role in supporting people's day-to-day health-related and functional needs. They're on the front lines supporting access to healthcare services. And with the workforce crisis and high vacancy levels, as well as high turnover, there's concern that this will negatively impact efforts to promote optimal health. We also know that DSP education about supports, including health-related supports, is frequently conducted on the job and may not always occur before working with the person. In addition, up-to-date information about the person's health risks and support needs may not be easily accessible to the DSP, particularly for those who are newer in their positions. The pandemic really brought to light a number of misperceptions about quality of life and the impact that unconscious bias has on health disparities for people with IDD. During the pandemic, IDD was the highest independent risk factor for contracting COVID-19. People with IDD were 6 times more likely to die from COVID-19 than other members of the population. And a new study that looked at the top causes of death among people with IDD in 2020 showed that COVID-19 was the top cause of death for people with IDD. So before we go on to our next section, we really just want to emphasize that, and we think this is important to today's discussion, that when healthcare needs for people with IDD are not addressed, we see increases in chronic disease burden, increase in health risk, increase acute care costs, including emergency department visits and hospital admissions. We see an increase in functional disability, an increase in Medicaid program, acute healthcare costs, and an increase as well in LTSS waiver costs as a result of the increased functional disability. And on the other side, first and foremost, we see a reduced quality of life for the people we're supporting. We see reduced health of the Medicaid program overall, and we lose our opportunities to bend that Medicaid program cost trend when we don't pay attention to healthcare needs for people with IDD. And then finally, because so many people in our states are dependent upon Medicaid for their health care, we see a reduction in the health of the state's population. So after laying that foundation, I'd like to introduce Dr. Craig Escudé, President at IntellectAbility, who will talk with us about the health risk screening tool.
Thank you, Lorene, for setting the stage and bringing light to all of the challenges that many of us are aware of and deal with on a regular basis. The rest of the presentation, we're going to focus on tools and really a new project that we think can really impact the health and wellness of people with intellectual and developmental disabilities. As Lorene said, I am the president of IntellectAbility. We have three divisions: the Health Risk Screening Tool, the Academy Division, which are e-learn courses, and our Person-Centered Services Division, which helps organizations to support people in more person-centered ways. For this talk today, we're going to talk primarily about the Health Risk Screening Tool. So some of you know what the Health Risk Screening Tool because you use it on a regular basis. And for those of you that don't, I'll give you a very brief overview. It's a web-based tool that's developed really to screen for health risks in people health risks associated with people with intellectual and developmental disabilities and really any at-risk population. So it helps to screen and identify health risks for people with physical disabilities, disabilities associated with aging, traumatic brain injury, and really any at-risk population. The health risk screening tool is used throughout the country, as you can see here on the map. There are 7 states that use it statewide in their waiver population, as well as a number of other states that use it throughout different residential provider agencies. So how does the health risk screening tool work? It is a very simple 22-item rating scale that helps determine the risk of health destabilization. It doesn't need to be completed by a nurse. It was actually designed to be administered by non-licensed personnel. And once a person is fully screened, they receive an overall healthcare level. That level ranges from 1, which is low risk, to 6, which is high risk. It identifies specific health risks to help guide the provision of healthcare and support and surveillance. And while it's nice to identify those health risks, where the tool really shines, in my opinion, is that it then produces action steps to help mitigate those health risks that are identified. These health risks come in the form of service and training considerations that help identify what services a person might need to help reduce those identified health risks, and also training recommendations to help ensure that staff are fully trained. Just to touch on this here, these are the 22 different rating items. You can see many of these are areas that we know there is increased risk, especially for people with intellectual and developmental disabilities, including swallowing issues and behavioral issues and aggressive behaviors and self-abusive behaviors, gastrointestinal issues, bowel function issues, injuries, falls, professional healthcare visits, emergency room visits. All of these things impact a person's life. And once the questions are answered, you can see here there's a list of scores here. So each area is scored, and then there's some logic built into the system, and then each person is assigned an overall healthcare level. Again, levels 1 and 2 being low risk, 3 and 4 moderate risk, and 5 and 6 high risk. This has been shown to be, the healthcare levels have been shown to be correlated to an increasing risk in mortality. So this graph here shows with each healthcare level from 1 through 6, there is a statistically significant increase in the risk of mortality. And this has been shown time and time again over the last several years of it being studied. And the validity was published, the information was published in the Journal of Nursing Measurement in 2020. And the conclusion of that study was the HRST can predict mortality and can serve as a basis for establishing healthcare needs and determining nursing care acuity. Now, we know that the health risk screening tool contains a wealth of information, a whole lot of information. But what we're looking to do here and what we're talking about in this project here is how can we provide the right information and the concise summary of the person's health risk to clinicians so that as they're seeing a person with an intellectual disability, they will know exactly where they have the highest levels of risk. So we've developed a document, and you can see that this is kind of the overview, the big overview of the document here on the left and on the second page that identifies for each rating item what a person might have and or what score they might have, and then what is the clinical significance of that document. So where will, if a person has a higher risk in a particular level, then that would be flagged, and it would be flagged in a way that would help a clinician be able to take a very quick look and get the information that they need. The idea and what we're talking about here is that this information and the concise picture of the health risk would be auto-populated into the electronic health record system that the clinician is looking at in real time when they're seeing the person. And those areas that score high would be highlighted, and the clinician can dive deeper to look at the expanding scoring descriptors with just a click if they want to go further into it. So the goal would be to provide clinicians with concise, relevant health risk information to guide clinical decision-making in real time. So I'm going to turn it over now to talk more about StationMD. I'm going to turn it over to Dr. Trivedi and to talk a little bit more about this effort.
Thanks, Craig. Can you hear me okay?
Yes.
Make sure. Great. And I'll let you know when we want to advance the slides.
Okay.
And first of all, I want to thank everyone on the panel, and specifically thank Anchor for having me on. It's been wonderful working with everyone on this panel on this specific project. I'm going to talk real briefly about StationMD first, about what we do and who we are for those of you who are on who may not know about us. So I think if you can go to the next slide, Craig. Thanks. So my name is Maulik Trivedi. I'm one of the founding members of StationMD, and we founded the organization in 2017 really with a simple mission, and the mission is to improve the quality of healthcare for individuals with IDD. We happen to use telehealth, telemedicine to deliver that care. I was an emergency medicine physician with 3 other founders when we started this organization, simply born out of what we saw in the ER. Individuals coming there with support staff or family members for reasons we thought could be handled elsewhere otherwise, and also by physicians who understood their needs. I feel very comfortable saying this because I was one of those doctors. Many physicians don't understand not only the medical needs of this population, but also the non-clinical issues that individuals face, provider agencies face, families face. It's a real gap in medical education. We kind of touched on that earlier in this presentation. The average clinician physician really has no idea what a DSP is, what a group home dynamic is, and it's really unfortunate. And we really felt that this population deserves a better quality of care. All of our physicians that work at StationMD are carefully vetted by us, board certified, but on top of that, go through a specialized training that Craig and his team at IntellectAbility provide. It's a curriculum that's geared to educate physicians about those gaps that they weren't taught in medical school, and that is absolutely critical because this population has medical concerns and issues that the average physician isn't aware of. It's all the way from the behavioral issues to constipation. Since the time we started in 2017, with a small cohort in the New York area. We have grown to 14 states, Missouri being a very big early adopter and one of the testing grounds, and has proven itself as a real kind of bellwether state, to covering over 30,000 individuals. Currently, just to give you an idea, last year we did about 31,000 virtual encounters just with individuals with IDD. So safe to say that we are very experienced, and rather than sending that individual to the ER where the clinician or an urgent care may not really understand those specific needs, now you are seeing a specialized clinician who really understands those needs of not just the individual, but also the agency and the family. Next slide. So why do individuals go to the ER urgent care in general? And part of it is due to the complex nature of this population. Outside of the underlying intellectual or developmental disabilities, individuals have other comorbidities, whether they be behavioral, GI, pulmonary. And even if they have a primary care physician, that physician may not always be available. They may not have the same technology we do to visualize someone, and by default, they end up saying the individual needs to go out to urgent care, ER. There's a general lack of access to medical care in general across the country. And the other aspect of this is individuals in this setting are often cared for by provider agencies who are burdened with well-intentioned regulations that have unintended consequences, and individuals and agencies are forced to send someone out to get checked. Our goal at StationMD, and in general partnering with IntellectAbility, is how can we treat this population in the least disruptive, most stable environment and provide personalized care. And there's nothing really better than their own home and their home setting. Next slide. So, the ER experience is frightening for anyone, but especially for someone with IDD. You can imagine that has sensory issues or nonverbal. I call it the trauma of transport, just getting them there. And I always use the anecdote. We work with some agencies prior to starting where if one individual in a group home of 3, 4, 5 people went to the doctor's office or urgent care, everyone got in the van and went because of the staffing crisis. It's extremely disruptive to their routine. Of course, you still have to mention COVID-19 and exposure not just to the individual, but also to the staff member that is going as well. And I put in here missed medications. In my years in the ER, I've seen many individuals come simply for a med refill because they can't reach a doctor, and it seems like everyone runs out of their seizure medications on a Friday night. These visits are disruptive to the individual, traumatic, as I've mentioned, and sometimes take days and weeks to stabilize and put a lot of individuals at risk. And there really is a better way. Next slide. So at StationMD, not all cases need to be emergent. We handle med refills, answer questions. Constipation, as I mentioned, in this population turns into bowel obstruction if it's not addressed. UTI turns into urosepsis. And there's really no reason that the individuals that are receiving this care or the support staff that are taking the care of these individuals shouldn't have access to trained clinicians who really understand those medical needs. When we started StationMD, we really didn't anticipate the staffing crisis and really didn't anticipate the impact we would have on agencies and staff. We have these wonderful DSPs and wage earners asking them to make clinical decisions about whether someone needs to go out to the hospital or emergency room, and now they have a resource for anything, whether it's a question, whether it's someone took an extra medication, whether someone fell and they need to go out. It's really, we want them to call us. Not every case needs to be an emergent case. Next slide. So, what is the problem? We discussed this a little bit earlier in the presentation, but the problem with the emergency department and urgent care, I would argue, is, as I mentioned, the trauma to the patient and exposure. It really is unspecialized care. And again, I feel very comfortable saying that because I was that doctor delivering that care. You have an individual that is coming to you, and this may resonate with some of you on the call. They come with a DSP who may or may not know them, with a big binder that looks like a phone book. I've never read anything in that. It's hard to find information. And I have 20, 30 other people, so I end up ordering many tests, and it's extremely expensive, as you can imagine. Unnecessary testing, unnecessary hospitalization. So you have this terrible combination of suboptimal care and excessive costs. Next slide. So how can telemedicine help, and how can a partnership between organizations like IntellectAbility and StationMD help and impact? So the lack of access. With telehealth technology, there are no geographic impediments. If there's a Wi-Fi signal or a cell signal, our physicians can provide this care. The suboptimal care and poor quality of care that this population has been receiving, all of our doctors go through the course and really understand the need for this kind of specialized telehealth. We have, as I mentioned, thousands of virtual encounters, so we've probably seen it before. We really understand the needs of not just the individual, but the family and the agency. We have our own medical records that we visualize someone, so we don't have to rely on that binder or phone book to find information. We also tap into the existing records that are out there, existing EHRs. And, again, we're providing this care, specialized care, in their own environment. We are available 24 hours a day, 7 days a week, and we provide full documentation of all of our encounters, and we coordinate that with the primary care doc so they have it. Next slide. This is just a screenshot of the portal that we utilize, and all of the partners that we work with have this. It has everyone's name in there, who called, when they called, chief complaint, the physician's note, the outcome, if a medication was written. You can draw reports off of this. It's obviously HIPAA compliant, but it is a full platform, and you can always refer back to this and see what transpired in the individual's care. And you can also trend things such as, well, now we have 2 or 3 people with a flu, and let's track that. But it allows the agencies that we work with and the states and payers to really have a record of what transpired. Next slide. So finally, I just want to talk real briefly about the interface, and really this is the meat of what this presentation is about our partnership with StationMD platform and the services we provide and HRST. So number one, it provides access to this data about the individual that we are making a clinical decision on. We have connected to HIEs and other health information systems, as I mentioned, also paper, such as the binders, but to have information that's concise, that has been validated, and supports my clinical decision-making as a physician and our physician's decision is really a game changer. We're able to look quickly at what that HRST tool has provided us, and then come up with a treatment plan rather than sifting through pages and pages of information, if we have that. And oftentimes that includes everything from a colonoscopy that someone had 2-3 years ago to information that's not necessarily relevant to what this telehealth visit is about. It oftentimes expedites our evaluation, definitely reduces the need for unnecessary testing and diagnosis, and really allows us to stratify how that individual needs to be treated depending on what level we see and depending on the information that we are provided. One of the things that we have discussed when doing this project is the more information, the better your decision can be, but you can also be overloaded with information, and you never will come up with a quality decision. And this combination of these two, I think, modalities of delivering care really ultimately will propagate that decreased ED use. And ultimately, what we're all looking to do is improve the health outcomes and the quality of life of the individuals that we serve. Next slide. I actually have to update this slide. This was an older slide where really has shown that it's actually more like 92% of the individuals that we see, we are able to keep in their home setting, meaning we don't need to send them out. So 9 out of the 10 times when StationMD gets called in conjunction with using the HRST tool, we think this will be even better. We're able to avoid ED visits. Next slide. And these are just some of the visits that went out. The blue are the ones that we avoid an ED visit or an urgent care visit. The gray are the ones that we send out. And so you can imagine these are the common clinical conditions and issues that you may see in your own population, all the way from med issues to constipation and cough and diarrhea, falls, fever, med refill. The gray are the ones that we do send out. And I will say that one other feature of StationMD is whenever we do send an individual out to the emergency room or urgent care, we will call in advance and we will speak doctor to doctor, clinician to clinician, You know, hey, I'm sending John to your emergency department for this specific issue, a leg swelling. He just needs an ultrasound. You know, try not to have him wait in the ER waiting room too long. He's going to decompensate. You don't need to do a CAT scan and blood work. It oftentimes expedites the care, not always, but also allows that clinician, that ER doc, to safely send that person back to the home because they know that, hey, there's another doctor who understands that individual and their needs that's going to follow up. The easiest thing for me to do in the ER prior to this was, let me order a bunch of tests and let me admit this individual because I don't really understand what's going to happen to them. Not only do I not understand how to care for them, but I don't want to take on that liability. And this type of solution really does allow that individual to safely come back and really live in the community. And that's really the goal here. Next slide. Finally, I just want to briefly talk about a partnership with a payer that we had, and I can also tell you an update on this slide. This was a partnership between StationMD and a payer that showed upwards of $2 million in savings in ER and hospitalization costs and transportation costs, roughly $1,900 per member after only 10 months. This was their data. This was a study done by the payer. And of course, we all know that there are tons and tons of great solutions out there that will impact the individual, impact the family, and really serve the population we're serving. But if there isn't a financial component to this, unfortunately, they are not sustainable. And a solution like ours, and especially in combination with IntellectAbility, is a sustainable solution that has not only an ROI on the impact of the outcomes and quality of life, but a financial impact. Again, because we are avoiding expensive ER visits and hospitalizations. I can tell you an update on this partnership that we have with a small payer with just 1,100 individuals. I think after over a year, they found the savings to be close to $6 million. So there is a real, not only outcomes in terms of individual outcomes, but a financial incentive to explore this kind of relationship. And next slide. Well, I think I'll turn it over to Jessica. Thank you.
Yeah, thanks, Dr. Trivedi. Can you hear me okay?
Yes. Yeah.
Great. Hi, everyone. It's great to be here today, even if it was last minute. And just really happy to be here with our partners at StationMD and IntellectAbility, and to have a chance to show you how this is working and contributing to really great outcomes at a state implementation level. So a lot of times we, as states and individuals as providers in states, are thinking, you hear about these great new partnerships and projects that are going on, and you're thinking, how do we get to that in our state and make sure that we have the best service for the individuals that we serve? So I am the director for our Developmental Disabilities division, but I'm also a family member. My husband and I have 5 daughters, and our oldest is 18 and has a developmental disability and needs a pretty intense level of behavioral support. So I'm coming at it kind of from both angles. And if you go to the next slide, really try to live the mission of, we are modernizing our entire health system at the Department of Mental Health, where we are enhancing the service models so that we can improve total health, because without your health, you can't live your best life. And that's really what we're here to do. So on the next slide, you will see that we kind of bucket this into kind of, how do we get there? How do we enhance the lives? We bucket that into 3 areas, which are very interrelated. So first of all, we want to improve individual outcomes, but the way that we do that is, in our path to get there, is by rewarding those who facilitate quality outcomes. And I loved when earlier I think it was Dr. Trivedi mentioned that, you know, most of the primary care physicians are not familiar with a DSP or what their role is. And when you think about the population that we serve, and of course, this is historic Medicaid lingo, so we all know it's not appropriate, but the age, blind, and disabled Medicaid group population is our most expensive population to serve in the Medicaid programs. And we really have not done justice in managing their healthcare conditions. And so that is, and a big part of that is we haven't connected the dots and all of the people who need to understand the total situation in that individual's life and how to leverage all of the DSPs that are in there on a daily basis. Just from an agency perspective and a system perspective, you have your most expensive population, and then you have someone that Medicaid is paying to be in that individual's home almost on a daily basis, if not daily, sometimes 24 hours, that it can be there to drive the outcomes for positive health outcomes. So we want to, we think the best way to get there is by rewarding those who are facilitating those great outcomes. And that allows us to be great public stewards of our tax dollars. So on the next slide, there is a breakdown of just the little bit more detail in terms of the things that we're working on in each of those areas. So the health risk screening tool falls into clearly into improving individual outcomes for us. And this is really all about healthcare access, the quality of it, and our ability to provide intervention when it's needed and in the right way. We have in there our social determinants of health and environmental accessibility, our technology, employment is very important. And then under the bucket of rewarding for facilitating those quality outcomes in the areas of life, we have some things there that really we think make a difference in terms of having a trained workforce, having a stable workforce. That's kind of all what we're working for now. But one of the main things that we're working towards is the value-based payment system, performance payments that leverage tools that we have put in place, great tools like StationMD and our partners at IntellectAbility with the health risk screening tool. If we can use those to give us the right data to pay for our providers who are providing great outcomes, then we can really make a difference and move the needle in terms of improving quality of life. And moving over just into being the great public stewards of tax dollars and how that works. This is really in terms of what we're doing, everything technology related is a big part of this in terms of we pay a lot of money for the ability to have someone go to the ER for a very unnecessary reason. Med refills is the #1 reason that we have StationMD calls here in the state, and there's no reason for that. And often when we have someone showing up at the ER, they might not even have that binder. They have typically now with the workforce situation that we're in, I think this will sound familiar to everyone, it's whoever's available. Usually the DSP that is in that home has to stay there, and then whoever's available might take, and they say, well, I don't really work with this individual on a normal basis, so I don't know much about their conditions, or I just have kind of the notes of what's going on. So it's this kind of third-hand information from someone who doesn't know them, and just really leading to a lot of inefficiencies. So on the next slide is we have some information on our website about the value-based payment model that we are developing and moving forward with. And this was really initiated quite a while ago in 2017, and then it really kicked off and got going in the technology realm through the LEAP grant, which was through the Office of National Coordination. And we had our partners at the table during this, and StationMD acted as a partner in terms of connecting technology and making sure that they were the primary care physician actor in a connect-a-thon that we conducted. There's information on our website if you want to go to about that. But we have built our case management system and the information in it to the ELTSS data standards so that the information can connect to the health information networks and feed into the information that is available to StationMD and to any primary care physician that would be serving them, so that they have the right information in a very timely manner in order to be able to make healthcare decisions about them. But if you've ever seen a person-centered care plan or an individualized support plan in the case management records, it's not very medical. And that's where health risk screening tool comes in terms of giving very useful information and in a way that not only can the DSP use it in terms of the health risk screening tool plan and how to implement what and address their health risks through those everyday things that the DSP is doing, but then that information about the health risks is also with that interoperability that is available to any of the physicians that are making decisions about that individual's care. And we really think that's kind of the secret sauce, best combination to delivering good quality care and having good health outcomes. Because when I hear physicians or behavioral health professionals, we hear this a lot, talk about they don't feel comfortable serving individuals with IDD. What often comes to mind is a little bit of from an advocacy and a family perspective, a little bit of well, that would be like you saying that it's a cultural competence. So it would be like you saying that you can't take care of a certain race or someone from a certain religion. This is really just about your competency to serve everyone, regardless of their ability or disability. And but we recognize, from a system perspective, that it's really our role as the state agency to give them the tools and the information that they need to feel comfortable in delivering that care and to feel competent in delivering that care. And so that is how we're moving forward in terms of what we can do as the state to affect the outcomes. On the next slide is a little bit of detail about what Missouri did with our initial venture into value-based payment. And this is kind of, like I mentioned before, a culmination of something we've been working on since 2017 and was recommended with the enhanced HCBS FMAP funding through ARPA that was available in our FY23 budget and recommended by our governor. So the value-based payment will, most of the time when you're beginning with value-based payment, you're starting off paying for data because you need to have those data indicators in order to inform your future payments and to know where you're having the biggest impact. So we have payments for data on our NCI information, our health risk screening tool information, employment reporting, but then we also had a lot of funding put in place to ensure that we are able to bring everything up to that interoperability level, including funding for our provider systems to connect with the health information exchanges. And so you can find more information about that on the website. The next slide is a driver diagram. If you've never done one of these, it looks really complicated, but when you break it down, it's just what are you trying to accomplish and how are you going to get there? And this is something that We started when we originally started our value-based payment technical assistance with CMS in 2017. And we said we really want to aim to decrease avoidable hospital ER utilization. And then we really had to look at how are we going to get there and what are all those tools that we need. And so you can go over that in more detail in the attachments when you have time, but this breaks down our plan, and our partners on this call are a big part of that. Next slide. So a little bit more about everything that plays into this. I mentioned before, we're all well aware, turnover rate for DSPs in Missouri is abysmal, like the rest of the state, or like the rest of the nation. So it's close to 60%, probably a little bit higher now. And then the next slide shows that the NCI data that we have that tells us that there are a large number of the individuals that we serve that are experiencing chronic health conditions that we really need to step up and find a way to make sure that they are able to be addressed and they're able to live their full lives. So going through the next few slides, that is data that we have collected from our NCI survey and really led to great data to help our legislature and our governor understand why we needed to make the investments in the health risk screening tool and why we needed to make the investments into StationMD. So StationMD in Missouri is I'm very happy to say, officially an HCBS waiver service. We have 4 1915C waivers in developmental disabilities, and it's offered to all of the individuals that receive waiver services. And all they need to do is make the phone call or connect through the app, and the individual, the residential provider, the DSP, the family, whoever is there and helping the individual or the individuals themselves can call StationMD at any time and get the support that they need to help understand if they need to go to the ER urgent care or how to address what's going on with them. We encourage them to call or make contact at really with any concerns that they have from a medical perspective. And then the StationMD doctors are there to, and Dr. Trivedi showed a slide with like 88%. It's always above 90% for a treat, treat at home rate for us. So the savings alone from the implementation of that, not to mention the increase in quality of life and the avoidance of impact on the workforce from having to send staff with someone to an ER. There's just so much positive outcomes in this service. On the next slide is information about, you can see we put a lot of resource information out there for our families and our providers to understand how to use the service and how it works. And then we have our health risk screening tool on the next slide. And that is something that we have started, and it is really going to be required by everyone in a waiver starting in July of next year. And so we'll have information and on all of the health risks and the health scores or health levels of all of the individuals that we serve, and really start to be able to break down that information and make decisions and see how the impact is going. On the next slide, you can see kind of where it all fits together here is that now we have a system where as we get it set up, we will have a individual who's in our waiver, and they will have their health risk screening tool completed with their plan, and that information will be available to their to the StationMD physician when they have a concern. So that family member or that individual may make a phone call to the StationMD physician, and they will be able to see everything about their conditions and their health risks, and then listen to the individual and family about what's going on currently with the symptoms, and be able to make a really informed decision about how best to advise them on what to do next. So this is really exciting for us going forward to know that we're going to be able to provide this level of support for the individuals that we serve. So I think that might be the last slide that I have, and just happy to answer any questions.
That is, thank you, Jess and Maulik and Lorene, and this is Craig, and we thank you all for joining us today. No webinar is complete without some technical difficulty, so I had one of my screens kind of go black while I'm while I'm doing this. So I'm going to try really quickly to remedy that so I can see questions. But please feel free to type questions into the question box should you have any. And as a reminder, you can download the handout for this this PowerPoint presentation in the handout section, and I will be emailing it to everyone after the meeting. So let me see if we have any questions and if I can get them to show up. So bear with me 1 second. Okay, I hope everyone is still there. Can someone answer me if you're still there? Excellent.
I'm here.
Okay, excellent. So we have a question. Someone just emphasized the importance of the staggering importance of data to make the case to policymakers regarding the ER avoidance using StationMD, and I would have to say it is a very impressive statistic, and I completely agree with that as well. Yeah, just the more we can treat people in home, and again, we think about policymakers, we think about cost savings, but think about the person themselves if we can treat them without having to go somewhere. So that's a great point. Someone asked, does the HRST interface with Epic and EHR systems? So the HRST can be integrated in different ways in terms of pulling in demographics and med data and allergies, things like that, diagnoses with just about any EHR out there. We have not had one yet that we have not been able to integrate with. And we're also working on another level of a project to facilitate integration with EHRs even better. And let's see.
And Dr. Escudé, I would add that that you all have also integrated with our case management system.
Yes, thank you for adding that as well. The last question I have is, will we have access to the recording? And the answer to that is yes. I will send the recording out along with the PowerPoint, hopefully later this afternoon, if not sometime midday tomorrow. Let's see. Are you seeing other states following Missouri's model? Does anybody else want to take that question? Or
we get a lot of phone calls. So Dr. Trivedi I jokingly say that I'm going to start charging him a consulting fee.
Yeah, I will gladly pay it. No, in all seriousness, when we started partnering it with the state of Missouri, it was kind of like right before the pandemic or close to the real peak of it. And I really have to commend them and Jessica and all of their organization on being progressive. And I look at the state of Missouri as kind of a beachhead contract or relationship. Many states have really followed their lead. And Jessica and her team have been more than gracious to explain what their experience has been, because I think at the end of the day, people are wondering, like, does this really work? And I think that Missouri took a chance and was very progressive. And to speak specifically on that, we are doing something very similarly in Ohio, in Washington, D.C. There's a few other states that are looking to follow their lead as well. And the one thing I really do love about this, the people we serve in this space in general, is it's very collaborative. You know, people look for best practices and want to share them, but that's a long-winded way of saying, yes, there are other states that are looking at this. We're looking to spread the word.
Yeah, absolutely. We are, you know, when you're in public service, that's really, states don't have all of the resources to independently research, and knowing just from a state perspective how it can be really challenging to convince legislative and funding decision makers to make an investment in programs when the state budgets are, you know, they have a statewide budget decision to make. And so being able to call on other states and talk through kind of both from the perspective of how did you work with your funding decision makers, to do you have data that we can help use for ours, to how did you technically get it into your waiver through CMS with the wording that you used. We are very happy to just share. You can copy and paste. There is no need for states to reinvent the wheel because every state has a best practice in a certain area. So we're all happy to do that. And I think the data that we'll start to have on the health risk screening tool in terms of what we are able to do to impact the, if any of my labor people are on here, the D prime, the Medicaid costs on the other side of the equation, the Medicaid medical costs. It's really going to show the impact and the opportunity that we had all along for the DSPs and the provider agencies to impact the health outcomes and the healthcare costs, and they should be rewarded and get paid for being able to do that. So we do have the training for the Fatal 5 through HRST in one of our other value-based payments. And then next year, we plan to include another level of value-based payment for the health risk screening tool trainings into our mix.
Well, I think that's all the time we have for today. If any of you have other questions, please reach out through email to any of us. And we look forward to sharing more later with the results of all of the work that we are collaborating together with. And again, just thank you for joining us today and for all of the work that you do in support of people with intellectual and developmental disabilities.
Thank you.
Thank you all.
Thank you.